I'm Emma Goodman from the Becker's team. It's an honor to be here. We are going to, we have a really fantastic established panel here today. We're going to be talking about going beyond the algorithm, maximizing AI in healthcare with a three-pronged approach. We have executives from Baystate Health System, Ascension, the UT Health Science Center at Houston, and Houston Methodist joining us for a terrific panel. But before that, I'm thrilled to introduce Karim Karti. He's the CEO of RapidAI and going to kick off today's forum. Thank you so much and enjoy.
Thank you. Thank you, Emma. So I'm not sure how we ended up planning this session in the middle of the eclipse. So either you don't have those special glasses or you're really interested in AI. So I'm sure it is the second. So I'm very pleased here to lead a short session of introduction before our esteemed panelists will come here and join us for a discussion. And it's a great opportunity to introduce the topic of AI and how we are actually implementing great, and very effective AI programs in many institutions all over the world. So many of you know the world of AI has obviously been quite explosive in the past 12 months. But it's been ongoing for a long, long time. Actually, our company was founded 12 years ago. In healthcare, there is over 1,500 today companies that have been founded in the AI space. And obviously, the advent of Gen AI has also increased the number of companies playing in this space. I have taken a very special interest in this field for a very long time. I was before the CEO of the GE Healthcare Imaging business. And so I had, obviously, it was a top of mind for a business like that to be really looking into what was going to be driving AI, and especially its impact in healthcare. One of the things I've seen actually in the early years of AI, and really shows you a little bit what AI is capable of, and I'm pretty sure many of you have seen and heard about the company DeepMind. The company DeepMind developed very advanced AI algorithms. And one of the first areas where they really implemented AI was actually how to play chess. I happen to be a chess player, a competitive chess player, so I took a lot of interest in this area. And I had actually an opportunity to see and talk to Garry Kasparov, who many of you may know. He was the world champion for over 15 years, and talked about what really happened with a program called Alpha Chess. And this is what actually the first really kind of instance of where AI was implemented. This was an algorithm that DeepMind provided the rules of chess and taught itself playing chess, just given the rules. Then it played against the best computer at that time, which was Deep Blue. At that time, Deep Blue already beat the world champion in chess. The equivalent of the rating it's called ELO rating in chess, is about 2,800 for a world champion. Deep Blue was sitting around 2,900. When Alpha Chess played 100 games against Deep Blue, what happened? When not a single time did Deep Blue won, but what was astonishing is it was a 60 win and then about 30, 40 draws. The ELO rating of Alpha Chess, which again taught itself chess, just following the rules using advanced algorithm, was close to 3,400. So just to give you an understanding, this is more of a logarithmic scale. So 3,400 is never seen performance, right, in the world. A world champion is at 2,800, a grandmaster at 2,600. So a 100-point difference is huge. 700 point is incredible. Here is the most interesting insight from that story, is chess at the highest level has been played for a long time in a very defensive way. So once you're a very high level, it's very tight games. Alpha chess played in a completely different way. So it revealed a new way of playing, which was extremely offensive and making moves that never anybody could think that you would be doing in chess. So it really, literally opened the mind, right, to new ways of playing chess. Obviously, the advent of Gen AI has also opened the mind on what can be done with the large language models. And you've seen now the profusion of new models based on voice, based on images, and this is going to be going exponential. Now, in real life, Gen AI, the first instance really of what we are seeing providing real impact in the real world is a company called Klarna. It's in the fintech area. It's actually a fintech European company. And a couple of months ago, they implemented a Gen AI service agent. It replaced 700 service operation people, providing $40 million of op profit increase to that company. Most importantly, which is astonishing, it improved actually all their service metrics. So not only it saved a lot of money, but it provided a better service. Again, opening the mind on what you can do differently. So clearly, we're in the beginning of the journey. There are not many areas that have yet been impacted by AI. But we at RapidAI, we've been in this space now for a few years, and we have impacted actually the stroke treatment in a very significant manner. And we really stand out by providing deep clinical AI. What does it mean? It means AI that provides information that is quantitative, that helps drive not only clinical decisions faster and better for patients, but most importantly, ends up to be better operationally for the hospitals, driving better transfers, driving better treatment, and most importantly, driving enormous financial gains. The increase in the procedures for most of the hospitals have been 3, 4, or 5x, what it used to be 4 or 5 years ago, because we implement this on a network level. We don't implement RapidAI in one hospital. It's really building a network and helping hospitals really have AI all over their network. And we're going to talk a little bit more about how we do that. I think one of the things that's important is first and foremost to kind of understand what we do. So in a very simple way, most of neurologists or neurosurgeons or neurointerventionalists have a RapidAI app on their phone. When a patient comes in the hospital through the emergency department, they get scanned. As soon as they get scanned, they usually get 3 scans: a non-contrast CT of the head, a CT angiography, and a CT perfusion. Those scans get immediately, in less than a few seconds, transferred to our servers. They get processed, and then at the same time, in literally a few minutes, all the physicians that are connected to this patient that needs to make the decision can see on their phone or on their PACS or on their desktop the results of the images, the analysis, the quantitative information. So on perfusion, you can see actually the amount of brain that can be salvaged. There is a whole analysis around it. And then based on that, the person who needs to treat the patient makes a decision. If he wants to treat the patient based on the analysis, he pushes the go button, and the whole stroke network team gets activated. Now, why is this important? Well, for brain, time matters. And this is why, saving 15 minutes, 20 minutes for a patient can mean the difference between speaking, not speaking, living or not living. And today, we have scanned over 20 million patients. We pride ourselves on being partners for over 2,200 hospital institutions. And we're continuing to advance the field by providing better and deeper AI, and we're going to talk about what is the direction. So one of the most important vectors on how we have approached the implementation of AI is really around how we are adding clinical, operational, financial benefits to every system. This is obviously obtained by very, very deep integration of workflow. A good AI program has to be very deeply integrated with the workflow. Second, a good clinical AI has to provide information that is actually relevant to every physician, providing actually information that usually sometimes is not available through the human eye. And this is, again, similar to what the CHESS program has done. We kind of opening the mind of physicians. So when we are doing the analysis on CT perfusion, on quantitative information and analyzing, what is the, where is the blood in the brain and which areas can be salvaged, we highlight that area. Very difficult to do through the human eye. Today, we do the same thing for aneurysms. The current protocol for understanding a brain aneurysm is looking at two-dimensional views of aneurysms and measuring the largest diameter through two-dimensional images. These aneurysms are three-dimensional, have different shapes, and the risk of rupture is really driven by multiple factors. And what we provide is actually a view that the human eye cannot do. We reconstruct these aneurysms in 3D views, and then we provide actually the growth of these aneurysms in a volumetric fashion. Again, something that the human eye cannot do. From an operational standpoint, we talked about the networks, and this is actually probably the biggest impact in stroke care. You have a hub, the main hospitals where patients are treated, and you have sometimes 10, 15, or 20 spokes. And the time to triage these patients usually results in patients not being routed to the hub or too late. What our system allows is actually to quickly and effectively triage patients and make sure that the right patients get to the right place. Because in stroke, you have very few slots. Most of the places have only one or two neurointerventional labs. You cannot, if you start to treat a patient who should not be, he's probably taking the place of somebody who should be, who's going to be coming through the operating room. This is why systems like this is as much about how you increase the number of patients that you're treating, but also how you're avoiding treating the wrong patients. Finally, on the financial side, the impact, as discussed, is tremendous. The number of patients treated through thrombectomy has massively increased in most of the systems we have implemented. That has driven increased revenue, but we have also huge benefit on lengths of stay, which are measured across an entire set of systems. So we have massive impact clinically, financially, and operationally. Now, what we have realized, working along all these institutions, is having a platform that's highly secure, that's scalable, and that's highly integrated with the different systems in the hospital is absolutely critical. And I'll repeat it again. If we're not integrated with workflow, AI has very little chance of having an impact. And so what we believe in is, having a platform that can do that. So our platform is highly integrated with the PACS, integrated with messaging systems, sometimes, EMS systems. We also integrate with EMRs. We're highly scalable, so we can provide as many capabilities as the hospital want. Some of our customers have, up to 20 of our AI solutions. And you need to be able to run them in parallel, because if you are waiting, serially, there will be a very long time. Last but not least, we innovated and provided a hybrid platform. because we observed, and many customers told us, hey, what happens if we lose connection to the cloud? And stroke patients cannot wait. And this is why we have built a hybrid platform. We have actually a platform that's on the cloud with the capabilities to revert back to an on-prem capability. So if you shut down the cloud access, you can revert back and fall back on an on-prem solution and be able to treat, those patients that are acutely, and severely impacted. Our solution now expands to multiple disease states, including pulmonary embolism, aneurysm, and so on. And we're growing in multiple clinical areas. And this really is the opportunity to do this with the platform. Now, again, not all AI is created equal. And I want to reaffirm one important point here is the difference between an AI that's having an impact and an AI that's not having an impact is really being able to provide information that's not readily available otherwise to clinicians. And second, most importantly, that's very easy to use and very integrated with the workflow. Now, if you look at our app today here, clinicians today, most of them are saying, hey, listen, Karim, I have gained my laugh back. Many of these neurosurgeons and neurointerventionalists, they used to not be able to go to dinner, not go, to help their children go and see, their game. Now, because they needed to be close to a computer and they needed to be close to the hospital because they were worried that they would not get the information fast enough. Now, with our application, they can actually on the go do literally what they want to do because they get alerted within seconds. By the time they make the decision, they have the time to drive to the hospital, and the stroke, care team is getting the patient ready. This is the same impact, by the way, for nurses, which are so important and critical for hospitals. We don't waste their time. They only get activated when needed. So the impact on physicians and nurses is immense. The future for us is not only to be able to provide good diagnostics. The future really in healthcare is about predictive capabilities. We discussed earlier, aneurysms, brain aneurysms. One of the most important things to be able to do is to understand whether a brain aneurysm is going to rupture or not. And that's what we're working on, those predictive capabilities. In stroke, many of you may know, because I'm sure it's one of the, biggest killer in the US and in the world. The ability for a patient to really survive stroke is their collaterals. And do they have good collaterals or not? Which means, when they have a clot, does the brain activate a different circuit, the collateral network, to save their brain or not? And what we're seeing is obviously the people who do not have good collateral, are suffering tremendously from stroke. Or can we predict who will have good collateral or not? And then can we implement different protocols for those who don't have good collaterals? So the opportunities really to impact patient care are numerous and huge going forward. We're working on many, many areas right now because we have accumulated now the data and the experience, and we have so many partners that really want to advance the care. And we actually have over 120 research projects ongoing right now in the space to give you an idea of, the numerous opportunities that sit in front of us. One of the things that excites me the most is when I sit with neurosurgeons or neurointerventionalists or stroke coordinators or stroke nurses. They are telling us, you guys are giving us superpowers. When a neurosurgeon who used to basically has to wait for emails and messages to look at their patients across 20 sites, And suddenly now on his phone, he can see the entire patients through their system, minute by minute. We're giving them superpowers at home. So this is a little demo of the Apple Vision Pro used with our software. And in the future, people will be able to be at home providing very, very advanced analytics and communication with the entire clinical care team. Today on our app, you can hit the button consult, and you can consult with anybody, within the care team. And you're controlling their phone from your phone, and you can show them exactly what's going on, and you can show them where to go and operate. For physicians to work with their residents, it's actually changing the game. So we look forward to the conversation with our panelists, and I thank you all for listening.
All right, let's get going. Appreciate everyone's patience as we sort of transition here. We're going to have a conversation really focused on sort of going beyond the algorithm, obviously maximizing AI in healthcare with a three-pronged approach. I've got some questions prepared, but first we're gonna operate this in sort of the standard way. I'm gonna have each of our panelists introduce themselves, share a bit about their background, and then we'll get into it. So we'll start on the end. Michelle, go ahead. I know you sat far away from me, but I'll make you go first anyway.
You did that on purpose. Yeah. Well, good afternoon, everyone. I'm very happy to see you all here, especially since there is an eclipse happening, just like you said. But anyway, Michelle Stansberry. I am with Houston Methodist, of course, within Houston, Texas. I've been there 31 years. I'm the VP over our Center for Innovation, as well as over in IT over all of our applications. That dual role serves us a lot of great purpose, and we'll talk a little bit about it a little later.
Excellent.
Hello, everyone. My name is Mary Schramm. I am the Assistant CNO at Ascension Seton Medical Center in Austin, Texas. I have been in that role for about a year now, and I grew up in the operating room.
So good afternoon, everyone. My name is Babatokbe Fatui. I do serve as the Chief Medical Information Officer for UT Health Houston. I've been I've been in the organization since 2019. Prior, I was in New York City Health and Hospitals in the same capacity. And after we implemented, sometimes in 2021, transitioning from our legacy system, I decided to stay. And right now, I do also serve as a chairman for the Center for Digital and Healthcare Innovation for UT Health Houston.
Thank you. Hi, everyone. I am Dr. Soumya Viswanathan. I'm the EVP and Chief Physician Executive at Baystate Health System in Tampa, Florida. I've been there a year and a half, and prior to that, I spent 30 years of my career was in various academic health systems in Boston, the Harvard system with Partners Healthcare, Dartmouth Hitchcock, UMass, you name it. I'm an internal medicine physician, and I wanted to share that we really welcome the fact that all of you decided to be in a closed room without any doors or windows. So during this eclipse period, if any of you really want to leave early and you need sunglasses, I have them. Just send me your addresses and I'll send you the bill later.
We're in this together, folks.
Hi, everyone. I'm Dave Stoffel. I'm a Chief Business Officer here at Rapid. I've been at Rapid for over a year now. But I've experienced about 25 years in medical devices, a lot of innovative technologies, including robotic surgery. I'm a physician by training, and then went over into the industry side. So really pleased to be here and share the table here with the rest of the panelists.
Excellent. Well, let's get into it then. And I think obviously there's a lot to talk about AI in healthcare today, rightfully so. And the majority of healthcare institutions are deploying it in some form or fashion. But I think still knowing where to get started or where to apply it the most is still perhaps a challenge for folks who are a little bit elusive. So want to tap each of you to share a bit about your own organization's journey into integrating AI. But David, I would love it for you to actually kick this section off with sort of a high level view of what you're seeing in terms of where folks are applying this technology and having success.
Yeah, just even taking a higher level approach and building off of what you heard earlier, AI is more than just an algorithm, right? is if many vendors out there, and I can't even begin to imagine from a hospital standpoint how many pitches you all get on a daily basis, some of them probably from us too. But what we have seen in the hospitals that are implementing AI most effectively and partnering with vendors most effectively is when they're looking at it saying, okay, are my AI algorithms really changing clinical decision making? A lot of vendors are out, a lot of algorithms are out there and they're not really changing any types of decisions. That's kind of step one. Thinking through that, though, is taking that algorithm and saying, is this available generally into my workflow? Saying, is it really, but the question really is it taking friction out of my system? Is it creating more friction for my physicians or my providers to use this? The answer is yes, then I think you're on your way. The final piece of that puzzle are people who are using analytics to really get the feedback on how that algorithm is going. And we have found consistently is that programs that are implementing all three of those elements are the ones that are really getting the most out of their AI programs. Every single one of those involves work and partnership with the vendors. It's not just the vendors coming and dropping a box and saying, hey, here, you're done. So it involves a lot of partnership and working with the hospitals. But that's really what we've seen where AI is making the biggest impact in the hospital side.
Where you're actually having that real collaborative effort
Exactly.
together.
Yeah.
Soumya, can you expand on this for folks in terms of your take?
Yeah, absolutely. So I think you nailed it. If we went through a process, even with radiology, we went through a process. We had X number of vendors who were coming, knocking on the door saying that we have an AI solution for stroke. Now, AI is the hype word. I saw a cartoon in New York Times the other day that said, one part they're all on a cruise ship and there's a group that's asking, how did you get approval? How did you get budget approval for this? And the response from the two members in that cruise ship was, well, I just used the big word AI, So basically, it sounds like, whether it's the Gartner's hype cycle, we'll talk about that later, where we are on the hype cycle, is it truly hype? Is it all logic and algorithm that people are using and calling it AI? So there is a lot of partnership that we as a health system have to do with the vendors to make sure that we understand you're not just using the word AI in your proposals, that you're actually truly delivering on that. The second thing we actually learned was exactly what you just described. If we don't bring the clinical teams into this early on and the operational teams, it is a failure model. We really have to make sure that the people who are going to use this, it's not going to create more of a burden on them. It eases the work they do because otherwise it's going to be a failure model, at least in service industries. In healthcare, which is a big service industry, we really need to keep that in mind.
You got to bring everyone who's actually going to be leveraging the technology to the table to have their voices heard, correct?
Yes.
Babatope, would you want to weigh in here too?
Yes, thank you very much. For us at UT Health Houston, the journey has been significantly transformative. And for those who might not know, we have about 7 other schools within as an academic institution. A key player is the McWilliams School of Biomedical Informatics, where we have lots of brilliant minds and health data scientists, programmers, and developers who also are eager to and they have data for over 20 years within the Texas Medical Center, as Memorial Hermann being our teaching hospital and partner. Now, we have vendors who also bring products day in, day out. We've invested heavily in our primary EHR system. So for us, we've come up with a policy of bearing in mind that AI is pervasive. This is a tool that's been in existence since the 1950s in one shape or form. Now, of course, it's now spreading like wildfire, and since this transition is very pervasive yet invisible, right? People are still using it in a lot of different ways. However, we prioritize the investments that we already have. If they have an AI tool, we'll check it out first for all of the vendors that we do have. Now, if they don't then serve as solutions, we then look internally to our own scientists who graduate from those schools and go work for the vendors anyways, and serve and work with them with our own findings. And that has generated 2 solutions. One is what we call ID fax, just helping with administrative service functions of having redundant faxes and the likes. We talk about to some people sometimes, oh, fax, you guys still do faxes? Yes, a lot of it. it's helped with referrals, scheduling, and the likes. Now, it's not primarily a physician need, but it helps with the mood and the tempo of the clinics when folks don't have to spend hours trying to reduce that. The other piece is utilizing predictive models for no-show, especially within the pediatric pieces. Many tools have that, but having data for over 2 decades, understanding holidays, understanding the dates the kids to go to school, understanding cultures, and deploying those models help us to predict patients who might not show, so we can either book more, call them, and improve physician efficiency across board. So our model is to check out what we already have, utilize what we have. If we don't have that, we can then more or less find solutions internally.
And in terms of like checking out what we have, I think the phrase you use is sort of pervasive and invisible. So folks are using this technology without even necessarily knowing it's there. I guess from your perspective, quickly before we move on to Mary, what is effective at sort of like getting the word out about like this technology in terms of because AI is I guess attached to a lot of preconceived notions people have of it, and they might not be aware that it's actually a tool or something, technology that's already supporting the work they're doing today.
Very good question. Thank you very much. So for us, governance is everything. And governance and shared ownership and inclusion really demystifies the whole concept around AI, especially for physicians. We went on with the generative in-basket since the advent of GP 3.5 and 4 and all, to help summarize and encourage folks rather than start from scratch. And by the time you try to respond to a message, it's kind of generated some prompts for you. Now, some doctors, this doesn't sound like me, this is stupid. They just want to start afresh. When we educate, yes, it's not supposed to solve all of these things. This is just one more tool that we're trying to take things you've been complaining about for years. I didn't go to school to do this. You hear that many times. I'm a doctor. I just want to see patients. I don't want to do X, Y, and Z. Education, inclusion, and just awareness has been very, very powerful. And we do educate, not just on the one-on-one, 7 times 7 ways through their staff, direct messaging and all. Amongst other things that I'll touch on later, just so you know, yeah. But the embracing the topic, knowing that it's still evolving, and talking to folks about it, letting them know it's not everything, it's just a little bit. No matter how sensationalized AI is, it's just like the last thing that came, and it can never replace you as a doctor. And of course, for some of you might have heard it, I was taking a course on EBAIM for AI. AI will never replace physicians. There's a possibility, though, that doctors who adopt AI might replace doctors who don't. So that makes people listen, and we begin to have a good conversation along that note.
There's been similar remarks made about journalists, but we won't go down that road. Mary, go ahead.
Sure. So in my role in particular, I'm able to bridge the gap between clinical practice and then our administrative directives. I think with AI, there's such a large database for us to tap into that we often just times keep going about our daily task. As nurses have a very specific checkbox of duties that they have to do, right? So what we've done is, in my role in particular, we've gone and we've asked questions to the clinical leaders. What do you need? What are you seeing, right? Often we hear that they don't have time to round on this patient, every hour, which is evidence-based practice, mainly because they are doing these checklists. So the way we've been able to kind of bridge the gap between the admin wanting to grow AI, and clinical practice is just asking them questions. So when we applied, I'll give a prime example. When we applied the increase in falls, we had a trend in that in our hospital. So we had this vast data set that we could utilize for our clinicians to be able to identify what is it on your task list that's most important. So when we went back, there was this fear of, well, you're telling me from this data that I only need to do this one thing. If I focus on this one thing in my checklist, right, I'm going to reduce falls in my area. And of course, we want to say yes, but the way we got buy-in is we like to term things a pilot in our area. So doctors and physicians and clinician teams don't feel like they're so set and that they have to, buy in all the time. But the term pilot kind of allows, hey, let's try it. Let's just try and see what we're going to get by utilizing this data. And that's, I think, giving that security and assurance that this doesn't have to be a for sure thing if it doesn't work, has helped us implement AI better at our site.
It's new, right? So
Yeah.
people have to have permission to make some mistakes, right? Michelle, go ahead.
Yeah, I would tell you that AI, and I know we kind of started off a little bit with clinical, but AI can be used in almost anything that you need overall within hospitals. It is not just clinicals, like you can use it for your patients. You can use it in each one of the clinical areas, as well as in your back end and your revenue cycle, which we have done overall at Houston Methodist in several instances. While it's amazing to me that AI is really getting all of the hype right now, thank you very much. It has been around for years. We pretty much started off using it for our virtual ICU. We worked with an overall organization to develop overall these predictive algorithms to be able to help us do early interventions overall within our ICU patients. So we've taken it from there. We've actually used it now. We've got 8 different hospitals, soon to be 9. So one of the things that we try to do in our Center for Innovation is pilot these new technologies with AI and to ensure, one, it's solving a problem for us in our organization and it's meeting the needs that we are absolutely looking for it on the outcomes. And then afterwards, what we do is we scale it. We're able to scale it very, very quickly across our 9 different hospitals. So I just want to give you a prime example overall of just a couple. So on our virtual ICU, we have a virtual command center that's staffed by clinicians. So it's very easy for us to be able to develop other virtual services by tapping into AI with that. So telestroke, telepsych, all of the others, virtual nursing as well. We have that rolled out across our organization. But the other piece, what we've seen with these early interventions is biomed devices. We now have a device that we put on with each of our patients in med-surg units that is capturing vital signs information. So we've been able to reduce the Q4 vitals overall in our organization by utilizing it. It also helps with early intervention because there's an alert watch capacity dashboard that comes with it. It's being staffed and watched by our individuals within our virtual ops center. The other thing, if you talk about clinician burnout, I think when you look at ambient intelligence, which is actually being used across a lot of organizations, what I think I have heard so many times is that look at physicians burnout and all the messages they get in their in baskets. And hopefully the 2 sitting over here could go, yes, I completely agree. But the AI that's been on top of that now responding back, and some of you don't, I'm sure some of you know, it's the MAs that are absolutely helping the physicians out overall as well. But the responses, the physicians, I'm sure they're busy and they're responding very quickly, but the AI that's generating those are coming out a little bit more empathetic than some of in the wording overall to the patients, and patients are preferring that. So the thing that I would just tell you, and I think there's so much potential here, but don't just always think it's in the clinical space because there is. I will tell you, we're also doing it for coding. That is a potential missed. Your coders are really great, but they're missing, I think, opportunities that are out there. So reviewing the data in that area.
It's good to know that AI is polite. Michelle, you're using this technology in a lot of ways, and it just seems like you as an organization, you've really embraced it. Is hesitancy still something that you come up against or misconceptions around AI? Do you still encounter in your organization at all? And if you do, how do you?
Well, the thing that I will tell you, change is hard. No one really likes change, to be honest with you. I think overall, some of the things that we've done on our nursing staff, for them, it was, what do you mean? That's my job. And then actually when we put it in place, they were extremely happy with it afterwards. I think it's the trust factor too. How do you trust the data? How do you know that the data is real? I would tell you we have an AI governance group that looks at everything. It's staffed by some of our data scientists that we have that review all of the algorithms and things that have been built within the AI. So that's helpful. But I think you just have to get out there and try it. I will tell you, and I talked a little bit about these dual roles. Our Chief Innovation Officer is also our CEO of our largest hospital, which is over 1,900 beds. So a very big facility. I will tell you there are times, and when you start putting cameras in your ORs, let me tell you what your surgeons think about that. So part of it is, though, operational efficiency. And we just said, look, wouldn't it be great if we could turn these ORs around faster to give you more OR time? So a lot of it is up to you having to get out there and overall prove it. Again, change is hard. And it's not just because you put it in, they will use it.
Thank you, Michelle. David, I want to jump back to you now. If we can bring that microphone back. It's a well-traveled microphone. David, I want to ask you, we sort of kicked off this portion of the conversation really talking about the characteristics you notice in organizations that are doing this quite well. And one of the barriers that has potentially come up is change and potential hesitancy. What other barriers do you notice in terms of as people are trying to add AI, do more with AI? What are they running into? What are some challenges you see?
Yeah, I think part of it is the awareness, and there is a hesitancy in education involved in saying, hey, we're bringing in an AI algorithm. And it's amazing to me, hear physicians saying, well, I think it's going to replace radiology. We just had this discussion out on the show floor. And I don't think anything could be further from the truth. One, there's not enough radiologists out there. And two, we need to find ways to make them more productive because, imaging, and I'm on the clinical side of the world, so that's where I'm focused. But the demand for imaging is growing logarithmically, and the supply of radiologists is growing linearly at best. So technology has to play a role in helping these people meet those productivity demands. But framing it in that way is that it is a partner rather than a predator, I think is a key way of kind of getting entry into this organization. I think another thing is to be able to spread the idea of kind of the vision of what it can do. I grew up in Iowa, and the system that my family was a part of, there are about 18 hospitals, and they're being serviced by one neuroradiologist. And when I was growing up, there'd be places like, man, you do not want to go to this hospital. You want to go to that hospital. And to me, the big vision with AI is that, man, you could take that one neuroradiologist and spread that knowledge so that every single one of the patients coming into one of those hospitals is getting the care of an equivalent of a neuroradiologist, or they're being covered. You're enabling that neuroradiologist to now cover more hospitals than ever. And that way, any patient showing up at one of your hospitals can get that type of care. Now, what's the barrier to doing that? Man, it is getting the vision and getting the physicians to buy in. It is getting the IT teams to cooperate because Lord knows, the IT teams are just inundated with requests. But if they can get clinical perspective on things, they can tend to prioritize things that are going to make impact. But it's the IT integration, then it's just the workflow. And man, I cannot emphasize that enough of what we've seen of people. If it is more work on the physicians or more work on the providers or more work on the IT teams, it's going to get rejected time and time again. So finding a way to get something that's integrated easily and actually where the juice is going to be worth the squeeze, where it makes people's lives easier, I think that is the key. But being able to communicate that and actually being able to realize that, have references instead of just coming out there and saying, hey, we have a package and it's going to be great, just trust us. Being able to go out there and say, hey, these people have done this before and we've been able to see it. All of those are ways that you can socialize the benefits of AI and also find that kind of trusted partner in doing it.
In finding that one message that's going to have broad appeal, right? Because I imagine you can tell a different story there about why that is, like the challenge you just laid out is very specific, but you can imagine like the vision you also laid out can really do a lot to solve that access to care problem. And so that's one story you can tell a group of people, but then you also have to tell in that story of this can improve the lives of your workforce as well. Do you find it easy to, I guess, tell those stories at once when you're trying to talk to all these stakeholders?
For us, one of the best testimonials we can do, it's not going to be from a PowerPoint. It's not going to be from me on a podium. It's from physicians talking to other physicians and administrators talking to other administrators. That way we felt like we can kind of sell that story, tell the story, but also sell the story from experience rather than just kind of making a very slick PowerPoint. So we found like peer-to-peer and that validation of looking to others who have actually done it well and hooking them up with people who are trying to learn how to do it has been the most successful way to build that awareness.
Thank you, David. So may I go into you now in terms of what barriers have you encountered, and would love to hear too what solutions, how do you get around them? How do you address them?
Absolutely. Thank you. So, if we were to break down the barriers, I think they classify under 3 different areas. One is just what you mentioned, is just the rollout, the implementation, and really finding out if the clinical teams are on board or not, getting the buy-in from those who are going to be the end users. The second one is cost, and I'll give you discrete examples of these as we went through our own exercise within the system. And the third one is this perception that AI is going to replace human beings. So the worry that our staff has that we are going to have layoffs, right? So that FTE reduction is always something that comes to mind. So I'll give you some examples. The first one is on just the logic, the algorithm, and the AI clinical change that we had to, implementation change that we had to go through. When we went with the stroke AI, so we have 14 AI applications we are reviewing currently. So at a given time, we have 12 to 14 applications that we review. We go through a very rigorous process of at least 4 different councils that have to vet this. And finally, it's everything inclusive, clinical operations, finance, and then it goes to legal, risk, all of the ones that we are used to. So with the stroke one, we actually had engaged with a vendor, and for all the reasons that was mentioned earlier by Karim, that did not work out for us. So what we found is the clinical team, the neurologists, the neuroradiologists, neurosurgeons had not been engaged in the discussions. The metrics were not set. The feasibility and the scalability of the product was not defined. We were actually getting, and it was in the early stages of AI development. So during the early stages, when we went with the initial vendor for a pilot, we learned that we actually picked up that it was picking up on infarcts and strokes on the wrong side of the brain. It was giving us delayed readings. So all these things, we just have to be careful. Anytime you have a vendor coming on board, we have to make sure if it's going to create a clinical impact that's going to negatively, adversely impact the outcomes, we really have to pay a lot of attention. So we learned our lessons. We said, okay, pilot is done, and we went with the next vendor, and the next vendor has absolutely fantastic results. We have accuracy, which are high, clinical accuracy, the acumen with which we are getting the results and the outcomes. The metrics were defined by our neuroradiologists and the neurosurgery team. So it's really critical for us to have that radiologist mindset that says, this is what I want to look at when I see the reports coming through. Now, I'm not going to name that vendor, but the fact that I'm sitting here talking about it will tell you who the vendor is. And anyway, so just wanted to share that.
You stole my follow-up question.
So just so you know, we have to really vet the logic, the algorithms with the right teams for us to feel comfortable. We are going through that same process now. Now that we learned the lessons through stroke, we are looking at incidentalomas, talking about radiology. Incidentalomas, 8 to 10% of them, at least in our health system, 8 to 10% of them require follow-up testing. So if that's how many testing is required, that's the ROI we are looking at from a patient satisfaction, patient experience perspective, from just even the financial ROI for the health system as the patients come back into the system and get these repeat testing done. Legal and risk mitigation, God forbid one adrenal adenoma is cancerous and we miss it, you know what the risk is going to be for the system. So clinically, I have to say that the clinical implementation, that first bucket, is really critical for us. And it can be a barrier, but it can also be a pro if we do it right. The second piece I iterated to was on the cost piece. So unfortunately, what we have found is, which is why we have to really vet, is this truly an AI vendor? Is it truly AI baked into your platform or not? Because the minute they use AI, we find that the cost is going up. We found that, so we used, as many of us did through COVID, we used the chatbots. So we use chatbots for triaging patients to the right level of care. So that was an easy no-brainer. It was COVID. Nobody really felt like they had to charge a lot. Now that COVID is done, or we think it's done, we are moving into these nudge mechanisms, right? So a lot of platforms are coming nudging. Patient engagement tool, they're nudging patients to come seek care. When you have the nudge mechanism, what we are finding is there are platforms that are coming out and saying, well, we'll charge you this much per campaign. So if you want your patient to get mammogram, if you want your patient, this is how much it's for mammogram, and this is how much it is for nudge mechanism of colonoscopy. So it's becoming expensive, costly for health systems to look at it that way. And so that is one of the barriers, is the cost associated the minute they put AI into the bucket. So our team does a lot of due diligence on the cost factor with financial analysis to say, okay, how many of these are really critical for preventive care? How many of it is being done anyway? What are the misses we are having? So we do a lot of diligence into clinical care, cost analysis, financial analysis. And the third one that we talked about is around, and I think one of us mentioned this, is around provider facing. So really looking at physician burnout, nurse burnout. We are on the DAX full scope, the full service, as well as we are doing the DAX co-pilot. So as you probably are aware, the Express or the co-pilot is a lot less expensive. It's only ChatGPT run. The other one has also a human interface, so there is somebody who's already looking at it. We also are looking at applications on CDI, clinical documentation improvement, and looking at how do we do that capture. So what we found interestingly is we have a fairly decent CDI team, really well run. I mean, we capture 98% of clinical documentation queries, and that's how much is furnished throughout the system, where we capture a lot of it in-house. So the minute we looked at an AI vendor, it was immediate no. It was just a no coming from that whole side of the department. So immediately we said, okay, we're not replacing FTEs. This is a supplement to the work you're already doing. It's anything that is dropped out, that's something that could have been missed, that we want to make sure we are supplementing for the work you're doing. So once we did that, we decided to pilot it. So we piloted. We've done it 2 times now with the same group. And the pilots have interestingly revealed that the number of queries, CDI queries, did not go down, that work was already being done by our team anyway, and the cost, because it was AI-driven, was a lot higher than the number of FTEs we had doing that work. So I think when you ask me about barriers, AI is fantastic as long as we can define and manage the cost within the budget that we have. Not everybody can afford AI-driven tools. If you can manage with the budget and reassure our teams that we're not doing this to lay off people. You know, right. If we have people in the cafeteria who have to leave because it's an AI-driven module there, maybe in 10 years, 15 years, that may be the case. We'll have robots running the whole place, the whole hospital. But as of now, we still have human beings who we need. So that's the assurance we have given to everyone. Yeah. Sorry, long-winded answer to your question.
You're good, Soumya, because you kind of took the conversation where I want to go next, where not so much talking about barriers now, but how do you make these selections, right? How do you, like you shared how you think about ROI. I want to hear some other folks, Bapatope, Mary, just how you think about ROI in approaching the selection of these technologies.
Very good, very good. To select, first of all, we have to look at where our shoes are hurting, what problems are we trying to solve. And for the sake of time, I'll just be very specific of what we did regarding high turnover in the front desk, people frustrated dealing with faxes. It's not clear. They spend manual hours trying to transition information from faxes into the EHR. Stack and stack of documents within the queue and the likes. We worked with our 3 vendors trying to find a way for efficiency. We didn't get much headway, so we looked to our internal team. They used some AI and machine learning magic, in this case NLP and the OCR. Some of you might be familiar with those, and they reduced the number of time for which so most of these faxes now can be read, seen, and picked out information and more or less connected directly into the EHR and spliced and put within the system. So now you have people clearing all the queues, less redundant duplicity regarding the faxes, and happier staff in that sense. They have more time to do other things to the tune of when it was more or less deeply calculated based on the timing, based on the fact that we can schedule our referrals on time. $2.3 million has been more or less saved within our own organization in that sense. I have others, but I want my colleagues to also chime in a little bit.
Mary, go ahead.
Yeah, I think for us, what we focused on as leadership is really what quality and safety measures were we still seeing gaps in. That's where we started, right? We asked our teams to kind of look at where is the most education needed, what's going to quickly show results for that buy-in. I will say one of the hardest things that I didn't expect to happen with implementing some of these AI tools with our quality and safety is the way that our clinicians were trusting each other. So we have a very broad span of generations that are now coming into our workforce. Gen Z has definitely been our early adopters. Well, our more seasoned nurses definitely have that hesitancy. So we did have to find that we had to pick a measure and really go with it so that we could have a specific metric that we could show that by implementing this one set of data, right, based on AI results of what's the best practice, it helped build that trust of, oh, it's not just early adopters, right? Gen Zers saying that, right? There is some data, some validity behind that. So I think when I think about implementing AI as a leadership, it was really focusing on one specific measure so that we could have results to show the team of how that was going.
And that ultimately helps drive buy-in. It's very clear, becomes very clear what the why is and what the goal is, right? Yeah. Michelle, I want to check in with you and see how you think about sort of selection process in terms of where you apply AI. I think you mentioned earlier there's so many potential use cases for this. So curious to see how you think about where you want to invest your time.
Yeah, well, I will tell you, we look at what problems we're trying to solve in our institution. And reality, look, everybody does. Everyone sitting at this table and out there at the healthcare system, there's multiple problems. And I think you have to decide which ones you want to tackle first because you can't tackle them all at once. But I will tell you, anything that we do from an innovation perspective, especially even with just AI, it has to have a solid ROI. Because look, none of us can throw money just to throw money around to be able to do things. So we're very, very diligent about that. So looking at the problems, we're all out trying to look for solutions, a lot of them with our vendor partners that are coming in working with us. What's the ROI on it? And then if the pilot's successful, we will roll it out quickly. But one thing I will tell you is those ROIs, depending on what they are, if it's reducing some of your expenses, if it's overall bringing in more cases or whatever it may be, or looking at quality stats, I will tell you, we follow up on those things really, really diligently. Because again, lots of institutions are really putting forth time, effort, money to be able to do these things. And so I appreciate you being able to say it. It's not only just the clinicians, it's the IT teams, it's the operational people, everything, putting in effort on these things. And so we just have to make sure that it's done appropriately. If we can't see something that it's not bringing a return for us, we won't do it. Or if we pilot something and it doesn't work, we walk away from it very, very quickly. But we learn from it as well.
Thank you. David, I want to come back to you and honestly just get your reactions to what you've heard on the panel so far on this point.
Yeah, I mean, at the end of the day, we're in a financially constrained environment. And so everything has to show an ROI. If we could just focus on clinical benefit, that would be fantastic. Unfortunately or fortunately, we also have to make sure that there's a financial return to the hospital. And we've seen that time and again in that, again, by focusing again on the clinical side, but if you're changing clinical decision making and taking friction out, following that all the way through, and the way we've seen hospitals measure that ROI is, are you adding incremental patients to the system? And that doesn't just mean, okay, more people are walking through the door. That means I'm getting all the referrals through my network of hospitals, and they're not being referred outside of my network. That's a huge one. So it's not just people walking through the door. It's making sure patient leakage in your system stops. That's kind of point one. And if I could make that point 1 through 4, that's what we hear continually through from hospitals. Then I think there's also the length of stay, reduction of complication. Be curious to hear what the rest of the panelists think. It's very hard to measure, but if you can have a discrete impact on length of stay, you're just increasing the throughput through the hospital. And so again, if you can show that decrease in length of stay credibly, then I think that has a big financial impact as well. And finally, it just comes back down to, if you can reduce operational burnout, then you're not replacing FTEs so much. You're not going through the learning curve. You're not having to recruit new physicians. So retention of physicians and providers is also another one of those financial benefits and those levers that we've seen people use.
Thank you so much, David. And we've actually just got a handful of minutes left before I turn it over to Jason Daniels, who's going to come up and speak for a bit. But I want to pause and use these last minutes to just go through, let each one of you give yourself a minute or so to share some closing thoughts, get to something you didn't get to share today, or reemphasize something. We will, Bapatope, you've been the middle child on this panel, so I'll let you go first for this one.
Very kind. I'm the in real life though, I'm the eldest child, so just
Me too. It's an important distinction.
For me, I would want to just leave every one of us with a reminder, because I know we all know, but a purposeful acknowledgement that collaboration in this space is the key to success, regardless of, because AI is going nowhere. And in collaborating, we will spend time to educate the rev cycle folks, your clinicians, your patient access individuals, the digital front door experts, as the case may be. And to be able to do that, that means you have to immerse yourself in the understanding of what you're going to talk about and how it's going to impact them in all of this. Collaboration is the bane of advancing AI within our own organizations going forward.
Thank you. Mary, what would you say?
Oh, wow. I think piggybacking on that is, it's definitely that collaboration. And AI is not going anywhere. So, finding a way for your organization and your teams to really buy in is what leaders need to do. If we don't, then we are going to be behind the times. We are going to see an increase in burnout of our staff and turnover of our associates, mainly because everyone else is going to be moving forward. So I think there's just a hard balance between finding an ROI factor and really implementing it on the clinical side. So I think as leaders and new incoming leaders, right, we have to really teach them how to show that collaboration and utilize it, because AI is not going away.
Yeah, collaboration, a big thing here today. Michelle?
Last piece of advice just I would tell you is you have to find those operational champions within your organization who are willing to drive this change, because it's not easy.
Thank you. Samia?
I think echoing everyone's sentiments, let's embrace it while we have it and go with the flow. The hype cycle that we talked about, we are almost at the peak, I think, of that hype cycle. So there'll be some time of trough of disillusionment that'll come our way. We just have to ride the tide and go to the plateau area as quickly as we can, because this is not going away. And healthcare has been late adopters, like Michelle said, to AI, but we are deep in it right now. So it's a beautiful, beautiful journey.
And maybe an opportunity for healthcare to not be a late adopter on something. Right? David, go ahead.
Well, as the youngest child, I appreciate and I'm comfortable with going last on these things. But no, I think it was well said by the panel. And the thing I would leave you with is think of AI not as a product, but as a program. As a program, it's a team sport. It takes multiple stakeholders and also feedback on how to optimize it. If you treat it like a vendor or just kind of a product, it'll most likely fail. road to success as a program.
Thank you so much, David. Thank you, panelists. Thank you, everyone, for attending, and thank you to RapidAI for letting me be a part of this conversation. Jason Daniels, National Director of Market Access and Hospital Analytics, will be coming up to conclude our talk today. Thank you so much.
All right, that was a great session. Thank you, panelists. I'm going to wrap things up here today to talk a little bit about what we're doing at RapidAI that talks on a lot of the topics that we just covered here. I want to start off first with how we look at bringing new solutions to the market. We want to make sure that we're aligning with a lot of the challenges you all face. As we think about the last decade, actually almost 2 decades now, we started with the triple aim, addressing lowering cost of care, better outcomes, but we had to keep the patient in the center. That went well. 7 years later, we realized we must also put the provider in the middle, otherwise we're going to result in physician burnout and things of that nature. And as we move to the last segment, the quintuple aim, we're making sure that we have access of care to everybody. One thing at RapidAI that we hold very true is that we try to address each of these segments. And I wanted to bring this up is that last year, Beckers, at the C-Suite conference, there was an interesting survey that went out. And there were 6 items that showed up as key challenges for health system executives, starting with financial constraints. You guys may all know in the latest reports last year, most hospitals are dealing with a less than 1% margin. So when we talk about purchasing AI, we need to make sure that the return on investment is there. When we talk about workforce shortages, healthcare is the second industry behind hotels and tourism to actually suffer from this shortage. And nursing in healthcare is at the top of the heap. But just beneath shortages of nurses is radiology. As we talked earlier, for every radiologist that enters into a residency, there's 3 vacancies. So again, for every resident that's entering into residency, there's 3 vacancies. And so we're not here to replace radiologists with our software. We're actually here to supplement and actually improve the workload balance for these radiologists. The third item that I just wanted to double click on here, and that's about cyber security, data security that Karim spoke to. Last year alone, there was 400 reports of data breaches in healthcare. And if a data breach happens to your health system and you're relying on solutions that are cloud-based, solely cloud-based, you may lose the ability to run these functions. And so here at Rapid, we take this very seriously, and we actually have this opportunity for you guys to now look at hybrid AI, where we can actually flex between the on-premise solution as well as cloud-based. So again, looking at the quadruple aim or the quintuple aim, one thing we really pride ourselves on is making sure that when we sit down and we talk with your executives, talk with yourselves, that we're addressing better outcomes. How? It's through the length of stay. It's about reducing complications, timely, accurate diagnosis, really improving the quality of life. When we talk about the total cost of care, it's not just clinical cost savings. It's about reducing some of the indirect and direct costs and really reducing clinical variation. As David and Karim both alluded to, one of the concepts you have with our solution is you have a neuroradiologist in the palm of your hand. Think about the expenses that you all are currently making for third-party teleradiology groups. Not to undermine that group, it's very important, but you can now think about the opportunity that AI could potentially bridge and provide your general radiologist expertise in the palm of their hand. When we talk about better care team experience, clinical workflow optimization, product implementation, data interoperability, and team training, those are all very important, and those are things we take very seriously here at Rapid. So much like you heard earlier, if you're going to develop a program of excellence for AI, you must look through the clinical lens of clinical excellence. In fact, there was a recent article that was actually supported by the FDA last year that talked about there was 59 FDA-approved imaging algorithms for AI. Of those 59, only 7 were deemed clinically meaningful. What do I mean by that? It was more than just triage and notification. It was about quantifying, characterizing, providing additional context so that there could be changes in the clinical decision-making. RapidAI was mentioned, and actually we have 6 of those 7 referenced algorithms. Operational efficiency. So we spoke earlier, it's about saving staff time, not just radiologist time, but every 30 minutes in a stroke case, for example, could impact 2.5 hours if you think about 4 to 5 staff members treat a stroke patient through their journey. And we talk about financial viability. At the end of the day, the financial viability with AI truly must have a clinical operational impact in order to show financial viability. Just real quick on RapidAI for those who aren't familiar with us. We were the first and we are the global leader in clinical AI. We're in 100 countries, over 2,200 hospitals. I think you just mentioned we need to already adjust this slide. We're close to 20 million scans, over 350 publications in 11 New England Journal of Medicine. RapidAI was born out of Stanford University by physicians for physicians. So when you think about who your AI vendor is going to be, one of the things to consider is it by physicians for physicians? And that's something that you can count on. As we've heard several times today, there's many forms of AI, whether it's operations, administration, transcriptions, claims, billing. Where we play at RapidAI is very deep entrenched in clinical AI, the clinical domain of the ecosystem. One thing I do want to share with you, you may all remember when the guidelines for stroke changed from a 6-hour window to a 12-hour window to now a 24-hour window. More patients are now eligible for life-changing, life-saving mechanical thrombectomy procedures. You can see the landmark trials between Swift Prime, Dawn, Diffuse. Those trials all relied on RapidAI to identify those patients. So we take a disease state, we go extremely deep with the clinical information, and we plan to do that in other disease states. In fact, we are moving into places of pulmonary embolism, aneurysm, and beyond. But it starts with a strong clinical foundation and a clinical anchor before you can start to establish operational and financial viability. Last but not least, we're not just a software company at RapidAI. We actually provide value-added services. What do I mean by that? It's important that when you seek out vendors that they provide 24-hour, 7-day-a-week services that actually can speak multilingual, that are actually offered beyond just certain regions. Customizable, our implementation team will come in and customize the solutions, work with your IT architect, the nuances or the variances of your EMR systems. It comes down to computer-led training and live training. At RapidAI, we actually have a very robust training program called RapidU. So for any folks that are in the room that are currently using RapidAI, one of the things we identify pretty early is that you're not maximizing your subscription if you're not taking advantage of our training programs, where we have live physicians as well as recorded physicians helping you guys better optimize the use of our AI software in clinical workflow. And I'll end with this, as we actually think about the ROI and the return on investment, much like an iceberg. If we're just talking about the price and the acquisition price of software, we're only touching the tip of the iceberg. It's really beneath the surface of the water where we're talking about the true value drivers. Is the AI driving a reduction in complications? Is it reducing leakage out of the system? Are we seeing a reduction in door-to-treatment times, door-to-needle times? Incremental procedures, as we heard earlier, we have several instances now with large integrated delivery networks here in the United States where we didn't just increase procedures, we doubled, in some cases tripled the procedure volumes. What does that mean? Less side effects, fewer complications, hopefully shorter length of stay, and more importantly, improving the efficiency or removing the friction out of the system, as you said, David. So what I'd like to end with this is come by our booth 526. We will schedule, either here or in person back at your institution, a customized return on investment for what Rapid and our entire platform can do for you and your hospitals. So I appreciate you guys' time today, and thank you.